Hi everyone and welcome back to Learn Neuroradiology. I'm Brent Weinberg. We're here for our second installation of Fast 10 Neuroradiology review cases. This is going to be part 2, cases 11 through 20. As before, we're going to take a quick look at some cases. We're going to quickly review about 10 cases. We're going to take a little look at about 1 or 2 select images for a case. Each case is going to have a multiple choice question. Then we'll take a quick review of the answer. If you want to see longer versions of these cases, there are longer versions in the board review playlist, so you can go back and check those out if you want. But this is really for quick hits, learn a few things, about 10 cases, about 10 minutes. So without further ado, let's go. So this first case is a 52-year-old status post fall. You've got an image from a CT. You've got an axial flare. The choices are craniopharyngioma, colloid cyst, subependymoma, or ependymoma. So the answer to this case is a colloid cyst. What you see here on the CT, there's a rounded and well-defined hyperdense mass in the anterior aspect of the third ventricle, right at the foramen of Monroe. On FLAIR, you'll see that it does not suppress, so it's different from CSF. These tend to be hyperdense on CT. They tend to be T1 hyperintense, and they don't suppress on T2. This can cause acute hydrocephalus, and that can be fatal, so these typically tend to be taken out. Case 2 is an 11-year-old with left-sided flaccid paralysis and status epilepticus. You have 2 images here. You have an axial CT, you have an axial post-contrast MR. Your choices are Lee disease, Rasmussen encephalitis, Sturge-Weber syndrome, or Alexander disease. So this is a case of Sturge-Weber syndrome. One of the reasons I'm showing you this is so you can recognize this abnormality on MRI. So what you see is you see tram track type calcifications along the cortex of kind of the right parietal and occipital lobes here. On the MR, it has a very unusual appearance. There's a lot of leptomeningeal enhancement all along the sulci. That's from abnormal veins and venous engorgement in those areas. You also see these abnormal deep veins. That's because Sturge-Weber syndrome is a failure of the normal cortical venous drainage to form. That leads to all of this abnormal venous congestion. You can see that one side of the brain will be atrophic or smaller than the other side. Sometimes you'll see that the calvarium is smaller. The classic appearance is CT, but if you see it on MR, I want you to be able to recognize it. Case 13 is a 13-year-old boy with 4-month history of nasal congestion and epistaxis. You should almost be able to get this case without looking at the images, but we do have 2 images here, an axial post-contrast CT and a sagittal post-contrast CT. Your choices are esthesioneuroblastoma, lymphoma, JNA or juvenile nasal angiofibroma, and nasopharyngeal carcinoma. So anytime you see a young boy with a nasal mass, you should be thinking about JNA. These are enhancing masses. They start in the sphenopalatine foramen. This is important. Like, remember, they start in the sphenopalatine foramen, not the PPF, even though these are like a millimeter apart. Remember that it's boys more than girls. They cause nasal obstruction. They often present with nosebleeds. They will often be embolized before resection to minimize the risk of bleeding. Case 14 is a 67-year-old woman with nasal stuffiness, loss of smell. These images, this is a coronal T1 pre-contrast and a coronal T1 post-contrast. Your choices are granulomatosis with polyangiitis. That's the disease formerly known as Wegener's disease, nasopharyngeal carcinoma, idiopathic orbital inflammation, or esthesioneuroblastoma. This is a case of esthesioneuroblastoma. What you see here is you have a mass in the right nasal passages and ethmoid sinuses. You see it has some intracranial extension, some edema in the inferior reaches of the frontal lobe. Anytime you have a mass with enhancement that extends through the cribriform plate, you should be thinking about 2 things, squamous cell carcinoma and esthesioneuroblastoma. In a testing situation, they will often be esthesioneuroblastoma. Sometimes you'll often see an intracranial cystic component. That's also said to be diagnostic of esthesioneuroblastoma, but I will tell you, you can see it on both. But in a testing situation, go with esthesioneuroblastoma. Case 15 is a 45-year-old man, status post-trauma. The question is about which complication is present. So we know this patient's had trauma. You see images from the bilateral temporal bones here. The question is, or the options are venous thrombosis, carotid artery injury, vertebral artery injury, or ossicular dissociation. So these are all complications that can occur with temporal bone fracture, which you see a temporal bone fracture right there. This is a case of ossicular dissociation. What you see here is in the left temporal bone, the malleus, or the ice cream of the ice cream cone, is displaced medially here. This is the incus. These should be sitting right atop one another. Temporal bone fractures can have a number of complications, including ossicular dissociation, disruption of the tympanic membrane, facial nerve. All of these things can be injured. In this case, though, what you have is an ossicular dissociation. Case number 16 is a 30-year-old with headache. You have two images here. There's a T1 pre-contrast and a T2. Your choices are low-grade glioma, cysticercosis, cortical malformation, or cavernous malformation. Give you a few seconds to take a look for the abnormality there. So this is a case of cavernous malformation. If you look in the inferior frontal lobe in the white matter here, there's a lesion which is faintly T1 hyperintense to both the adjacent white matter and gray matter. On T2, what you have is a rim of siderosis with central T2 hyperintensity. This is a sort of classic appearance for cavernous malformation. What you'll see is there's no edema around this, not much mass effect. These are benign collections of disorganized vessels, although they do have a risk of hemorrhage. The risk of hemorrhage is a little bit less than 1%. The familial ones are a little bit on the high end of that range, like 0.5 to 1%. The spontaneous ones are a little bit less than 0.5%. The familial ones are associated with genetic malformations of the CRIT gene. So if you see that, that can be a question that you can sometimes see. If you have a developmental venous anomaly next to it, so an abnormal kind of tree-like branching venous structure, that can also help you clinch the diagnosis of cavernous malformation. Case 17 is a 19-year-old woman with trigeminal neuralgia. Got some images through the CP angle here, T2, T1, diffusion. Your choices are arachnoid cyst, epidermoid cyst, schwannoma, and meningioma. Now in this test, I want you to definitely get all the CP angle masses. These are the classic ones that you often will see in the description. This is an example of an epidermoid cyst. The characteristics you have of this is you have an expansile mass here. It's T2 bright, very similar to CSF. Similarly, on your T1 post-contrast here, it's very similar to CSF, maybe faintly brighter. But the thing that clinches the diagnosis here is on diffusion. It's very diffusion bright. On these two, you cannot tell if this is an arachnoid cyst or an epidermoid, but the diffusion hyperintensity here clinches the diagnosis that this is an epidermoid. If you see the same thing without the diffusion abnormality, it's an arachnoid cyst. Case 18 is a 33-year-old woman with thoracic kyphosis. You have some images from a chest CT and a thoracic MR. This MR has contrast. It can be a little bit hard to tell. Your choices are aortic aneurysm, meningocele, schwannoma, or aneurysmal bone cyst. This is a case of schwannoma. What you see here is you've got a mass centered in one of the thoracic neural foramina. You've got a little bit of expansion of the neural foramen here. You've got this kind of bulbous mass coming out here, almost in a dumbbell-shaped appearance. This one's not perfect for the dumbbell, but sometimes you'll see a little waste at the neural foramen. This is one of the most common masses arising in the neural foramen. So these are often extradural masses here. When you see these, they can sometimes be associated with neurofibromatosis type 2. So if you see one, look for another. Think about syndromes they can be associated with. Case number 19 is a 50-year-old with foot pain, cough, and fever. Have some images through the pons here. Got a T1 and a flare. Choices are multisystem atrophy, infarction, Behçet's disease, or osmotic demyelination. This is a case of osmotic demyelination. What you have here is you've got abnormality in the central pons here. It's almost trying to make this trident-like shape, but if you see it's pretty bilaterally symmetric, it crosses the midline. Infarcts often will respect the midline and they'll be seen on only one side because the perforating arteries supply only half of the pons. In this case, though, what we have is osmotic demyelination. About 50% of cases of osmotic demyelination are in the central pons, hence the alternate name, central pontine myelinolysis. More recently, though, it's been recognized that they can occur in other regions, including the basal ganglia, white matter. The most common thing associated with this is abnormalities in serum sodium. However, it can be associated with other abnormalities like hyperglycemia and other osmotic abnormalities. So just be aware of that. So if you see that in the history, think about osmotic demyelination. And finally, case 20 is a 40-year-old woman with visual difficulties. Here we have some images from CT. This happens to be a post-contrast CT, but it doesn't really matter. Your choices are sarcoidosis, thyroid orbitopathy, idiopathic orbital inflammation, and lymphoma. This is a case of thyroid orbitopathy. What you see here is the extraocular muscles are enlarged. They're almost enlarged symmetrically, so most of the extraocular muscles are involved. You see there's relative sparing around the myotendinous junction with the globe here. That's kind of a classic finding for thyroid disease. You see that there's no involvement of the lacrimal ducts and other structures like you might see with sarcoid, IgG-related ophthalmopathy, or lymphoma. So that really leads us to believe that thyroid disease is the most likely diagnosis. Now there's this kind of acronym that helps you remember the most likely order of involvement in thyroid eye disease. So it's I'm slow or inferior, medial, superior, lateral, and oblique. So that can tell you a little bit about which ones are likely to be involved. In this case, though, they are all involved. All right, thanks everyone for tuning in for cases 11 through 20 here. We're going to have more of these cases coming up, so be sure to like the video, get subscribed so you get notified. We'll have those videos coming up shortly. Want to get these fast-paced cases to you as you review for your exams. Thanks for tuning in.